not in the stable form like we discussed in the last week. We have highlighted last week some differences, especially in the pathophysiology between the stable ischemic heart disease and the acute presentation of ischemic heart disease, which is acute coronary syndrome. Acute coronary syndrome. And maybe, is there anyone remember what actually the main difference in the pathophysiology hallmark between the stable ischemic heart disease or stable coronary heart disease and the acute coronary syndrome? This one from the slides from last week. What is the difference between both? It seems no one expects questions just in early in the morning, right? Okay, this maybe. Okay, if you remember, brothers and sisters, and if you don't remember, actually in the pathophysiology we talk about the stable ischemic heart disease. We have a bit of stable atherosclerotic or lipid plaque in the artery that's stable, and thrombosis may happen, but the main feature it will be stable. And the acute coronary syndrome, as we'll discuss today, is all about this. The lipid plaque are not stable, become rupture, and this rupturing have maybe some accumulation of platelets and other component, and may lead to thrombosis that sometimes can be partial or sometimes can be complete. Okay. Just to maybe reflect back a little bit about what we have already discussed last week, because I will not, I think we were not able to repeat it again, but we can discuss and contrast, inshallah, between both. So hopefully we can better understand. So actually we have, inshallah, we will highlight some differences even, and some data on the different presentation of acute coronary syndrome, as we will highlight. And we will discuss the treatment algorithm, and the treatment approach for both of them, the STEMI and unstable angina and STEMI. All this will be explained later. Also, we want to understand actually a little bit in the details and the benefit, the place of benefit even between each pharmacotherapeutic category and the agents, which one is better, which one to be introduced, which one to be used here and there. This the place and benefit of each intervention also would be of interest. And of course, toward the end, we have, as usual, we will highlight the long-term management. We'll highlight some overall monitoring plan, and of course, the patient care process, as we used to do in the revision. So we can test our knowledge at the end if we are really maybe understand and grasp all the important points regarding the topic or not. Okay. Are you ready to start?
Yes, doctor.
Okay. So as you mentioned, the acute coronary syndrome has different presentations. So we can say it is a spectrum of condition. The hallmark or the common between them, it is acute, of course, unlike what we discussed last week. And of course, this ischemia will lead in most cases, not all cases, in most cases will lead to infarction, and this infarction will affect the coronary blood flow. And that's how we have the cardiac attack. There's not enough blood or no blood even, no longer in the coronary circulation. For our knowledge, just maybe from the pure clinical side point of view, MI or myocardial infarction can have many presentation, and the universal definition of myocardial infarction have identified as a clinical subset around 4 subsets of myocardial infarction. But this one for the management is not that maybe relevant to go in details, but we will discuss today the most common presentation, what we call type 1 MI, which is actually the common and the frequent and the one caused by the thrombus formation and the rupture of the atherogenic plaque. So as I highlighted in the very beginning, when we call the atherogenic plaque rupture, this is very important, the rupture. If atherogenic plaque is stable, so we don't have any acute coronary syndrome. The cascade of this maybe clinical presentation of acute coronary syndrome is affected by the rupture of this atherogenic plaque. This rupture will maybe open the door for many prothrombotic substances to be there, to be released, and platelet activation and aggregation start to take place. And maybe at the very end, the thrombus formation will be there, and we have as maybe a clinical endpoint, we have a partial or total occlusion of the coronary artery, which is very dangerous and very serious, of course. Okay. So when we talk about ACS, we have 3 main types, but in the management we have two maybe management pathway, because 2 of them, the non-STEMI and unstable angina, will be will be managed by the same way. So in the first place, we have STEMI, ST segment elevation myocardial infarction. ST segment elevation myocardial infarction. This actually refers to a type of myocardial ischemia that have the ECG will have ST segment elevation, and of course we have positive troponin. All this will be explained. Positive troponin, this is one of the cardiac enzyme that give us indication that infarction or tissue damage is going on. Okay, it is an indication for immediate coronary angiography. In STEMI, most of the time, as we'll discuss later, inshallah, this is the most severe and the most serious presentation of ACS, and most of the time, the effective management will be the immediate angiography, the invasive approach, as we'll discuss later. The other type, or the other approach, maybe of the clinical classification, will contain two types: the unstable angina or non-STEMI, non-ST segment elevation myocardial infarction. So non-STEMI is just, maybe you can say it is maybe similar to the STEMI in terms of the myocardial infarction or the myocardial injury takes place. But of course, the ECG and the ST segment elevation and depression will be, of course, different between both. Unstable angina is also one of the points, but unstable angina not really associated by the tissue damage. I will show you in a few seconds, inshallah. So when we talk about ACS, so we have 3 clinical conditions: STEMI, non-STEMI, and unstable angina. But as I mentioned, in terms of treatment, will be 2 treatment modalities or 2 treatment approach, because the non-STEMI and unstable angina are closely related condition, and most of the time will be managed by the same way. All the time managed by the same way, same treatment recommendation. And you find in maybe our main references, all the time non-STEMI, unstable angina management all together. The ECG abnormalities and the elevated troponins are insufficient to make diagnosis, because of course the clinical presentation sometimes will be atypical, and sometimes the pattern of the elevation of the cardiac enzymes will not be that maybe consistent, or finally can give the diagnosis. Most of the time, maybe all the clinical profile means the clinical presentation, the cardiac enzyme, the tissue injury, the ECG, all together will be needed to make the decision. this very important when we talk about optimal inhibition of the thrombosis will be the most important in the ACS management. This is the very important, and we can see in the treatment, inshallah we'll discuss thrombosis management. Antiplatelet, anticoagulant is very important and very vital in the success of the ACS management, and can be offered even in all the approaches that we'll discuss later. Okay. Is there anyone have points? Can proceed?
Can proceed, Doctor.
Okay. So just maybe to make it clear for us before we start maybe discussing diagnosis again, we have the non-STEMI, the ACS, the unstable angina. We have non-STEMI, and both of them, as I mentioned, grouped together and can be subjectively presented even the same. But you can see between the unstable angina and non-STEMI, the difference in the occurrence of the myocardial infarction or the myocardial injury or the tissue damage. Okay, you can see here in non-STEMI, of course, the myocardial injury takes place. In unstable angina, there is no myocardial injury. Okay, in terms of ECG, the ST segment depression, not elevation, will be there. And of course, if no myocardial injury, so no positive biomarkers. When we talk about the biomarkers, troponin or whatsoever, this indicating the myocardial injury. So if no myocardial injury in unstable angina, so we are not expecting to see any positive biomarkers that we'll discuss later. And you can see in non-STEMI compared to the STEMI, we have here maybe the severe form or the extensive injury will be in the STEMI one. STEMI most of the time will be need to total occlusion of the coronary artery, and this will make sense for us later when we talk about the upper hand or the preference of the immediate invasive strategy in the STEMI to just open the artery. Okay, open the artery and restore the circulation again. And of course, in STEMI compared to non-STEMI, of course, the ST segment elevation and maybe the positive biomarkers also will take place. The clinical presentation in terms of symptoms, more or less within the same, but the severe presentation will be there in terms of severity of the clinical presentation. Okay. So just to have some highlights about STEMI and the ranges and how serious it is. We have the recent data from the national level, from the National Cardiovascular Database, acute coronary. You have, I think, the national database for ACS in Malaysia here. And you can see the mortality, the in-hospital mortality, the 30-day mortality, the 1-year mortality following STEMI in range of 10.6 up to 18% respectively. And this quite high, okay? 18 out of 100 patients in 1 year following the STEMI will be die. And this is very high and very serious condition. Patient receiving reperfusion refer to the modality that we apply in the STEMI immediately, the invasive one, to open the artery. Whether the PCI, the balloon that we show previously last week, I show you the picture of the PCI and the cabbage, and the fibrinolytic therapy, the thrombolysis, the fibrinolysis that we also discussed. And we can see that patient reperfusion in general, immediate one, will have a better survival and better chance to have a better survival rate. The patient who had PCI, the percutaneous coronary intervention, also discussed last week, the balloon, the stenting. The patient had PCI during the index hospitalization, during their hospitalization, will have a better short and long-term survival compared to others. This overall, the data may be governing the epidemiology. one of the points that also we need to understand that relatively the incidence of ACS in Malaysia is affecting younger population compared to similar country in Southeast Asia and Asia. The mean age of ACS patient in Malaysia about 58.6. Thailand 63, Singapore, you can see the figure 68 and above. Okay, so it's relatively affect younger population compared to others. So this all regarding the introduction. Do you have any question, brothers and sisters?
So far, no question, Doctor.
Okay, good. Okay, so this point or this section we will go and discuss a little bit about the diagnosis and risk stratification, and it is good to know that as usual in the clinical practice, when we talk about risk stratification, so most of the time we mean this one because it will guide the treatment. It will affect what treatment option to be offered. Okay, so in terms of the diagnosis, as I mentioned, the myocardial infarction, the MI is defined as myocardial injury or myocardial death. Okay. Most of the time we use the term or prefer to term MI, and the I refer to infarction to make it very clear. It is just related to the ischemia, because injury of myocardium can happen perhaps due to ischemic and non-ischemic reason, but infarction refer to the injury or the tissue damage come or precipitated through the ischemia. MI is diagnosed by most of the time. For MI to take place, we have a certain feature. The first one, the clinical feature or the clinical scenario, that it will be consistent with chest pain of ischemic origin, which is maybe the main clinical presentation of ischemic heart disease. The ECG changes, either depression or elevation, based on the clinical type, and the imaging evidence of new loss of myocardium, the tissue damage, the image of the evidence of tissue damage, and this can be precipitated as loss of certain tissue or abnormal parts in other tissue in trying to remodeling or compensate. And of course, by the end of the day, in the myocardial infarction, we look for locating the thrombus. Of course, the thrombus will be there. How fast and how maybe rapid you act on the thrombus and you can reopen the artery will actually have very direct and impact on the overall prognosis of the disease in a given case. So what we expected by laboratory abnormalities, of course, we see or we hear due to, in the past few minutes, cardiac biomarkers. So the cardiac biomarkers will be one of the main laboratory abnormality, actually to differentiate between different types, and they guide or indicate whether the tissue maybe infarction is there or not. And actually ACS, as any acute maybe condition, will be accompanied, will be associated by acute systemic inflammatory response. That's why we will see all the markers or all the maybe the parameters that can be linked to inflammation or indicate inflammation also is expected to be high, like the ASR or CRP. The very specific, the lipoprotein changes will take place, and this actually happen in a pattern that differs from one protein and one biomarkers to another in terms of when to go, when to elevate, and when to maybe return it back during the recovery phase. But the lipoprotein in general will begin to decrease after the first day, after the first or 2 days after the events, after the attack itself, will begin to decrease, and will reaching the nadir, means the lowest value within 5 to 7 days, and then begin to recover again. And hyperglycemia is not that specific, because many patients, maybe regardless diabetic or non-diabetic, will have or will expect to have this hyperglycemia in place. When we talk about cardiac biomarkers, because this tend to be specific and the hallmark of the disease progression, cardiac troponin are the recommended one. We have the cardiac biomarkers. We have maybe troponins, CKMP, the myoglobin. We have so many, but the troponins, INT, of course, very specific, will be very sensitive and specific to the infarction that happened, especially due to the ischemia. And the one good point, it has a prognostic value. Prognostic value means that the level itself can be correlated with the cardiac mortality. The higher level, the higher cardiac mortality. This one is very important. The troponin level may not be elevated if the test done early. As I mentioned, in terms of the biomarkers, we have a pattern of the change. So troponin mostly will be significantly elevated after 6 hours. So if you take the assessment of the troponin is just early before 6 hours, so it may be misleading, and better, if that's the case, better to have a repeat test to be done within the 6 to 12 hours to be indicative really to what actually the troponin level in this case. Beside the troponin, we have CKMP. CKMP, of course, the problem is show more rapid decline, compared to the cardiac troponin. So sometimes it have a value to detect if there is reinfarction. If there is reinfarction, it has some value to guide this one, but it is not that specific and not that sensitive compared to the troponin. And we have also myoglobin. Myoglobin, actually, it is not cardiac specific. We cannot claim this myoglobin is really cardiac specific, or can be as sensitive as the troponin, and can be detected as early as 2 hours after the onset of the chest pain. So from this one, overall, the cardiac troponin is the one. Here you can see the pattern of how or when to elevate and to come down for as a comparison between the troponin, the CKMP, and you can see here so early that the CKMP can reach the peak and come down so early compared to the troponin. So the interpretation actually should take into account the timing for both. Here you can see maybe all together the troponin in the green one, and the troponin T and I, they may be very near to each other. And we have the CKMB, as I mentioned, is so early, and maybe extra early the myoglobin there. And you can see some of the other markers or proteins that cannot be really significant in terms of a peak to be done and the pattern, because most of the time they have like maybe flat or plateau across the illness. That's why we rely more on the troponins in general, INT. Okay. So by the end of the diagnosis, we have just maybe to go one of the pathways. Okay, if patient come with those maybe probable clinical presentation for SAS, chest pain or whatsoever, so most of the time at the very beginning, the ECG, if no elevation, so we are somewhere here in this domain. If there is elevation, so most likely you go for the STEMI. Here, after the you see it has been reported as no ST segment elevation. So still here some work to be done in terms of risk stratification in terms of the troponin, the cardiac enzyme, because here, as we mentioned, it can be unstable angina, it can be non-STEMI. So which one need further assessment? So for this one, of course, after the said troponin will be evident whether no positive troponin or no positive biomarker, so it is unstable angina, or a positive biomarker, this non-STEMI. Here in the other side, okay, this ST segment elevation with clinical presentation, and the troponin, of course, will be high. So in this one, we need to intervene with the strategy to reopen the coronary artery, which we call reperfusion. Reperfusion means reopening of the coronary artery, either by the PCI or the fibrinolysis or fibrinolytic therapy, and proceed to the pharmacotherapy as required. Okay, this overall may be a differential between the both agents. As I mentioned, one part of the clinical assessment of the diagnosis is very important: risk stratification. You see here we highlighted risk stratification because it depends on moderate or high risk or low risk, some actions to be taken. Okay, especially in the non-STEMI. STEMI most of the time will be high risk, but the pathway for the unstable angina and non-STEMI has to be maybe identified or a group, either it is low risk or moderate to high risk, because the treatment modality will be different, as we will explain. So risk stratification, we have so many risk maybe calculators that take into account many aspects and many findings in the assessment of patients with ACS. So it comes to include or integrate the clinical history, the ECG, the renal function, the troponins, all together. Okay, and the importance of this risk calculator or risk stratification, as I mentioned, it will guide where the patient could be managed, because if invasive strategy needs certain settings to be ready for this one, will also affect the choice of the antithrombotic therapy, and this one we will discuss, and of course guide the need for the invasive management compared to the medical management. In the risk scores, we have so many of them, but maybe most important and the most common one, we have the TIMI score. We'll discuss later in the next slide. We have the GRACE score, the Global Registry of Acute Coronary Events, and this actually many factors are there, and by the end of the assessment, the patient will be having score from, I think, 100 to 100. Maybe 80, something like this, but all the scores higher than 140 are considered high risk. Means has to be a candidate or to be intervened with early invasive strategy, as we'll explain. Risk stratification here in the events or the ischemic, or the risk of the ischemia or risk of mortality from the ischemic events. Closely related to this one, also the patient has to be assessed for the risk of bleeding, which is maybe the very common complication in ACS. As a complication, the bleeding. So bleeding tendency or bleeding complication or bleeding risk is also one of the points to be considered when you assess the overall risk of the patient. So we can see that hemorrhagic complication in general are independent risk factor for the mortality in the ACS. So you can imagine that the patient have already ischemic complication, already total occlusion, And if this coupled with the hemorrhagic complication in terms of the management, the outcome will be not an optimal one, and the mortality risk will be much higher. And for this risk of bleeding, so for the ischemia risk or the mortality from the ischemic event, we say GRACE score or TIMI score. For the bleeding risk, also we have so many scores. Just for example, the acute horizons one and the Crusade bleeding risk score that you can access even through the provided link. The common one in the ischemia event that I have highlighted, beside the GRACE score, we have the TIMI score. TIMI score, the thrombolysis in myocardial infarction risk score. And this risk score actually have a different scoring for STEMI and non-STEMI. And by the end of the assessment, the patients will take points, and according to the total points, you decide if this patient actually will be under which category, the low and moderate risk, and will be high risk. High risk 6 points and above, and this is the percentage of the 30-day mortality risk. 30-day mortality risk if patient categorized under the high risk category. Okay, you can see age, weight, systolic blood pressure, heart rate, CLIP class 2 to 4. This actually clinical classification of the heart condition, starting for the mild heart disease, proceeding to the severe heart presentation. The ST segment elevation, the diabetes, and time to treatment when the patient presented after the attack. Okay. You can see here, brothers and sisters, how it is different. The mortality risk in 30 days in relation to the risk score. So the higher the score, the more the risk. And you can see here, if score above 8, it approximately 36% the mortality rate in a given case, in the scale, of course, from 0 to 14. This is the TIMI score for STEMI. Okay. What about the TIMI score for non-STEMI? Non-STEMI, as we a bit maybe we can understand now, non-STEMI in terms of the severity is less, and in terms of the TIMI score, the score which is a bit different from what we have highlighted in the non-STEMI, and even the interpretation is quite different. We can see here 0 to 2 is under the low risk, 3 under the intermediate risk, and 4 will be 4 or more will be the high risk. So most likely the high risk score means need for invasive strategy. TIMI score, you can see the non-STEMI here, how different the mortality compared or in relation to the risk score. If you remember, when we talk about the STEMI, the maximum or the mortality can be as high as 36. Here you can see maybe the mortality is 6.5. Here the all-cause mortality is 19.4, 20. So in general, will be less mortality risk compared to non-STEMI, and less serious compared. The non-STEMI will be less serious compared to STEMI, less mortality risk compared to STEMI. Okay. Okay, brothers and sisters, are you following?
Okay, doctor.
Okay. So now we discuss maybe a bit of introduction. We discuss about the diagnosis and the risk stratification, which is the assessment, and we highlight this diagnosis and risk stratification is important in guiding the treatment. So now we go for decision for invasive management. How we can utilize this risk assessment to guide the treatment, of course, which as we highlighted, the invasive strategy has or constitute an important part in the management of the ACS. Okay. So in STEMI, of course, our primary goal, we want to reopen the artery. Reopen the artery, total occlusion of the coronary artery. So we want to restore the patency of the infarct-related artery and minimize as much as fast as we can, minimize the infarct size. This is a primary goal. The secondary goal, of course, after this, we want to prevent further complication that can happen, consequences to the myocardial death or myocardial infarction. Very common the arrhythmias, very common the further maybe life-threatening arrhythmic condition that may happen. And of course, we want overall to control the symptoms on the long term. Require urgent revascularization. Revascularization means reopening, reperfusion, reopening the artery, either by the balloon, the tool, the PCI, or the drug therapy, the fibrinolysis therapy. The primary PCI in general is a preferred approach compared to the reperfusion, revascularization using the medication. Okay, so the primary PCI is preferred, and the performance measure, which we highlight overall, inshallah, this performance measure include the goal to perform the primary PCI within 90 minutes of the first medical contact. Once he appears, within 90 minutes, the PCI should be done if the facility permits. The fibrinolytic therapy will be indicated for those patients in whom the PCI cannot be done. For example, the facility or the hospital has no setting or no center for the PCI, no trained staff. So the PCI cannot be done. So fibrinolytic therapy to be done. So if PCI cannot be done within the first 2 hours, the performance measures means the goal, the KPI, the indicator for the proper care, the performance measure for the lytic therapy or the administration to be done with door to needle. Door means since presentation needle, since the injection, door to needle time of 30 minutes. 30 minutes. Okay. What about the STEMI? So now we understand. Okay, that's what about the non-STEMI? We understand in the STEMI. We have a major role of the revascularization that can be done either by the PCI or the lytic therapy, and the PCI within the 90 minutes, and the lytic therapy, if PCI cannot be done within 2 hours, within 30 minutes, door to needle to be offered. What about the non-STEMI? Non-STEMI, of course, the goal to prevent the total occlusion, because currently in non-STEMI we have a partial occlusion as we highlighted. So, of course, we want to prevent the progress to the total occlusion, and of course, we want to control the chest pain. The patient with non-STEMI, unlike the STEMI, they have, according to the risk of either the TIMI or the GRIS score that we have highlighted, will be either a candidate to go early invasive, means we have to intervene earlier by the PCI or CABG, or ischemic guided therapy, just focus on the medication. So ischemic guided therapy is the approach in which we focus on maybe optimizing the medication that can help to prevent the total occlusion of the artery, and we want to avoid the routine early use of the invasive procedure. Okay, this is the approach. So we focus on medication and no invasive procedure to be done at the moment. Recommended for patients with low risk. Low risk means TIMI 0 or 1, GRACE less than 109 or 109. Indicated for those patients with acute chest pain is low likelihood of ACS. If patient is not, this chest pain is maybe overlapping with other maybe medical impression or medical conditions and not confirm the ACS, of course, will be more conservative approach to just focus on that on the medication rather than exposing the patient of invasive procedure that most likely they will not get that benefit from. The early invasive approach in non-STEMI. Of course, this we call about the angiography. Angiography, the procedure, so we can maybe help to restore again the partially occluded artery and assess even the coronary vascularization in general. The routine invasive therapy is generally superior to the ischemic guided therapy in patients with those risk factors, which all of them reflect patients with high risk. Okay, so advanced age, older than 70, previous MI or revascularization, ST segment deviation, the heart failure, the resting ventricle left ventricular ejection fraction less than 40%, if you want to maybe to make it brief. Non-invasive stress finding like high TIMI or Gravity score. So the high-risk patient, we found the evidence recommend that routine invasive therapy is superior than the ischemic guided therapy. This what we can maybe take a message from here. In high-risk profile non-STEMI patient, early invasive or routine invasive therapy is superior to the ischemic guided one. Okay, so now, brothers and sisters, I think by somehow you understand the approach for the STEMI, okay, and how important the reperfusion strategy, either by the lytic therapy or the PCI. We get to know the non-STEMI, and non-STEMI we have ischemic guided medication or invasive strategy, angiography, and the invasive strategy to be offered in patients with high-risk features. These high-risk features include, but not limited to, advanced age, other comorbidities, the troponins elevated, the high-risk scores that we discussed, and other findings. Okay? Can you follow up to now?
Yes, doctor.
Okay, good. Okay, before we go for the specific treatment, initially for all ACS patients, they have to receive what we call supportive therapy. Supportive therapy upon presentation. This supportive therapy include pain management, include oxygen, include nitroglycerin, of course the aspirin and beta blocker within 24 hours. This a general measures that can be considered in patient with ACS in the very general means STEMI, non-STEMI, whatsoever. And some of the reference label this one as a supportive measures or the supportive therapies that could be offered. We see here the morphine, the oxygen, the nitroglycerin, the aspirin, and the beta blocker. Okay. So just maybe to make it very clear from the very beginning, the treatment algorithm for non-STEMI and the treatment algorithm for non-STEMI, and the STEMI. Just take 30 seconds and maybe look at this algorithm, and then we can discuss. I appreciate if anyone from you brothers and sisters can try to not to highlight what she or he found in this algorithm. What is the most important regarding the non-STEMI? Of course, all the details, the names of the drug or whatsoever, we'll discuss later. But from here, what initially you find consistent what we have discussed. You can unmute the mic and just proceed.
For non-STEMI, we have firstly we have support therapy, like you said before, like oxygen, aspirin, and so on.
Okay. What about here in the STEMI? You can see also the supportive therapy, right?
Yes.
Okay, good, sister. Good observation that the points we have highlighted, like the supportive therapy, as we mentioned, it is general in non-STEMI and STEMI in there. What else, brothers and sisters? What else you maybe you notice in the figure overall? Initially, I provide this algorithm in the end, but this time I bring it earlier because I think it may help to make it more clear for us when to have a prior image of the treatment and the medication for the overall treatment algorithm. Okay, let me maybe go here, brothers and sisters, for non-STEMI or non-ST segment ACS in general. You can see it is either way. We have two major maybe pathways. What we call early invasive strategy here, and this one we discussed. This one could be reserved for patients with high risk features. And high risk features, we know now what high risk feature means: the age, the comorbidity, the troponin, and the risk score, right? And you can see here the ischemic guided approach, which is maybe avoid early use of invasive procedure, means you just give the medication. Just give the medication. Okay? So, brothers and sisters, what do you think here? If you want to compare the dual antiplatelet therapy here and dual antiplatelet therapy here, what is the difference? And associated with this one, what is the difference between the anticoagulant here and the anticoagulant here? What we can say here, you can see maybe it is aspirin, clopidogrel, ticagrelor. Here the clopidogrel plus or minus the P2, the glycoprotein 2 3A agents that we'll discuss later, which has a place or can be recommended in high risk patients only. So these agents cannot be seen here. This one, the anticoagulant, you can see here the unfractionated heparin, enoxaparin, the fondaparinux. Okay, you can see here beside all these we have bevacizumab. Bevacizumab, one of the maybe considered relatively new anticoagulant that could be or has to be offered only in the invasive procedure, not the ischemic guided. Okay, that's why it is not here. And here the approach is already maybe in the acute setting. It is just the medication focusing on the antiplatelet anticoagulant, and later in the late hospital care, the patient continue the aspirin, continue the clopidogrel or ticagrelor, anyone, and to be instated on the long-term management that we will highlight later, like continue the beta blocker, has the statin, had the the ACE inhibitor, ARP, and evaluate whether or not it needs spironolactone or aldosterone antagonist. That's all regarding the ischemic guidance. Here, the early invasive approach, beside taking this one and this one initially, this one here should be considered for the revascularization. Revascularization, of course, on the assessment, if the patient is eligible to go for the invasive procedure, will be revascularization. And revascularization, the invasive approach, as I show you maybe in the last lecture slides, that either to be coronary artery bypass graft or the percutaneous coronary intervention, and for all of them we have certain specification whether to what you do for the already initiated antiplatelet. For example, in the CAPEG, or regardless urgent or elective, you continue the aspirin and discontinue the other B2 or Y12 agent like the ticagrelor or clopidogrel. And after the procedure, you just continue with the unfractionated heparin and discontinue the other anticoagulant. What about the PCI? The PCI, the dual antiplatelet therapy should be there, and the anticoagulant therapy with either one also could be there. Okay, this overall maybe data on the non-STEMI management. So non-STEMI, just I want from you just to maybe to have in mind the ischemic guided, the invasive one, ischemic guided, maybe what the pattern, what the medication to be offered, the early invasive, what the order of medication we give, dual antiplatelet and anticoagulant, of course, and then assess revascularization, either CAPH or the PCI. Clear, brothers and sisters?
Clear, doctor.
Okay. So compared to non-STEMI that you already you see here, we have the STEMI. Okay. In the STEMI, you can see maybe in this side. In this side, very specific, very clear one, and I will go later for this one. Here, brothers and sisters, you can see in STEMI, besides getting, of course, the supportive therapies that we have highlighted to be offered to any SAS patient, we have a decision. We want in the first place to see the reperfusion or the attempt to reopen the coronary artery has to be done, and to be done, it is dependent whether or not there is a facility for the PCI or no PCI, the percutaneous coronary intervention. If PCI, the PCI facility, so the primary PCI to be offered, as you mentioned, by the first medical contact for the PCI to be done with the less than 90 minutes, and this the medication to be offered, and we can see here prasugrel beside the clopidogrel ticagrelor as one of the antiplatelet option. And the anticoagulant therapy in terms of the PCI, we can see here fractionated heparin and bivaloidine alone. Okay. On the other side, non-PCI facility means the primary PCI cannot be done. So the fibrinolysis has to be conducted within 30 minutes of the arrival. The dual antiplatelet is there, the aspirin, clopidogrel, and the anticoagulant options here in the non-PCI. The fibrinolytic therapy has to be administered. You can see enoxaparin and fondaparinux. Here, no enoxaparin, no fondaparinux. And then the late hospital management exactly the same. Here, actually, this one for me, I found it more clear, so I began with this one. This one from your CPG, just also to understand. Here, the supportive or the overall maybe supportive measures that can be done at the very beginning, and here you can see the assessment for the reperfusion, whether the PCI or fibrinolysis indicate or dependent on the onset of symptoms, less than 3 hours. So maybe the primary PCI or fibrinolytic therapy, if 3 to 12 hours, so it is primary PCI. If more than 12 hours, neither nor, and you have to go for the medical therapy. And of course, it has some relation. Sometimes the primary PCI, and then you can offer fibrinolytic, and sometimes the PCI also can be offered. And after this one has been managed, of course, the list of the concomitant therapy, dual antidiuretic therapy, statin, beta blocker is, and the mineralic corticoid agonist has to be offered. So I prefer this one. For me, it is more clear, but this one, because of the national CPG, this one interested just to highlight. Okay? Okay, brothers and sisters?
Okay, doctor.
Okay, you need the break before we continue?
Yes.
Okay. Okay. We have a break. You want 5 or 10 minutes? Okay, we have 10 minutes. 10 minutes break, and then we continue. Okay.
Kira, thank you very much.
So
Thank you, Dr.
inshallah we continue exactly at 9:10 inshallah. Okay. See you back inshallah. Assalamualaikum.
Waalaikumsalam, Doktor.
Okay. Okay, brothers and sisters, we in the first part we have discussed maybe hopefully hopefully now we are maybe a bit understand the the ACS STEMI and non-STEMI and what are the main differences between them in terms of the scoring, in terms of the severity, in terms of the management overall, right? I hope. So right now, inshallah, we will discuss a bit in details regarding the medication. Okay? So if you remember, we have highlighted that thrombosis management or antithrombotic, maybe antiplatelet or anticoagulant, is of paramount importance in the pharmacotherapy for ACS, STEMI or non-STEMI, okay? So patient with STEMI and non-STEMI should be treated with antiplatelet or anticoagulant therapy. This the shared recommendation. Both of them has to be offered, and I think this statement now should not be strange for you because you can see here the antiplatelet anticoagulant in the both domain for non-STEMI, right? And you can see here the antiplatelet anticoagulant for even the both pathways for the STEMI. So this statement should make sense for you now. So what are the general recommendation actually to put it maybe in some more details? Usually in the ACS we have a combination of it is not monotherapy, antiplatelet, and you have a combination between more than one antiplatelet usually and anticoagulant, and this one will be normal with in the management of all the type of the ACS. And in general, all patients receiving the aspirin and the P2Y12, this clopidogrel, ticagrelor, or prasugrel, and the minority from them will have this additional the glycoprotein 2B3A inhibition, the one we have highlighted under the high risk non-STEMI, if you remember. Okay, you remember, brother and sister? You can see here. You can see this one. Okay. I'm trying I'm trying to connect because actually the topic is I believe it is easy, but it is maybe a bit have some details, the points. If not connected properly, I am afraid maybe you can be lost. But if you connect it, inshallah, it will be fine easy. So dual antiplatelet therapy, aspirin plus one of the other agents, will be in general recommended for ACS patient for at least 12 months. This is a general recommendation, okay? The optimal, the low dose aspirin, the 75-100. What are the other agents besides the aspirin? We have clopidogrel, prasugrel, and ticagrelor. Usually we have some differences between them in terms of the pharmacological properties or pharmacological maybe information, duration of effect, the onset, and the initiation of loading dose and maintenance dose for everyone, and whether it is prodrug like clopidogrel or prasugrel or active drug like ticagrelor. These are general differences that's important for us to understand, of course, the starting for each one and the maintenance dose for each one and the duration of the effects. But what is maybe also clinically more important, it is the indication, because sometimes we see clopidogrel, ticagrelor, and later in the STEMI we say prasugrel, right? You remember something like this? You want to go back to the algorithm to see? No harm, no harm. Here, brother and sister, you see prasugrel? Here? Under the STEMI?
Yes.
Okay, here you see prasugrel. No, right? Because by indication, brothers and sisters, what important for us to understand by indication, clopidogrel and ticagrelor are valid or indicated for both medical management or PCI. It is not restricted. But prasugrel recommendation is all in patients with ACS who candidate for the PCI. Okay, this one. And what about the surgery hold time? Surgery hold time, if patient go to surgery, what actually the days should be held to avoid bleeding? This 5 days, and this 7 days. And you can see here the bleeding risk compared to other. We have some information that recommend that clopidogrel is less risk of bleeding compared to the other two. Okay. And here the risk of non-captured spontaneous or fatal bleeding higher than the standard dose of clopidogrel, and here the risk of the capped bleed higher than the standard dose of clopidogrel. Here just maybe important maybe notes, clinical notes on the differences between them, and of course maybe you can expose to some data on the interaction between the PPI and clopidogrel, whether it is significant or not significant. There is some more data on this one. Maybe you can refer later. And of course, the issue is the bleeding. So if you take non-steroidal, if you take oral anticoagulant, if you take omega-3 fatty acid, of course, this may exacerbate the bleeding risk. And prasugrel, no clinically significant drug interaction in terms of the PPI whatsoever, but the bleeding risk is very significant. Ticagrelor, maybe patient with bradycardia, patient with asthma has to be cautioned. There's some more data on this one. And they are capping for the maximum dose of simvastatin or rovastatin if they are the offered statin, preferably to be kept at 40. Limit the aspirin dose not to exceed 100, and do some monitoring digoxin for the digoxin concentration. All of these actually have some underlying causes. If you are interested, we can discuss later, but let us maybe move. Prasugrel and ticagrelor, in general, what we have to understand, in terms of potency, they are more potent compared to clopidogrel. Relatively, they have fewer drug interaction, but the reported risk of bleeding considered a bit high. For invasive strategy, prasugrel or ticagrelor can be considered in lieu of the clopidogrel. The prasugrel, the agents that maybe were found in the PCI, can be used only in patients who are candidate for the PCI, as those patients are not high risk of bleeding complication. The patient then can be benefited least from prasugrel are relatively old patients, more than 75 years, or those relatively weight less than 60 kilograms. This actually, brother and sister, this observation means when we observe offering prasugrel to this patient population, they found that prasugrel is least effective among this population. It is not contraindicated, but least effective will not be the better choice to be offered in this case. So to summarize, here we have the non-STEMI, ischemic guided, or non-STEMI invasive. So non-STEMI ischemic guided, clopidogrel, ticagrelor, either one with aspirin. The invasive you can consider ticagrelor, clopidogrel, and the invasive can prasugrel, or of course if the PCI. STEMI with PCI, of course, prasugrel, and then STEMI with fibrinolytic therapy, clopidogrel is to be offered, just to be with the less risk of bleeding. You can see the agents may be related to the glycoprotein 2B3A, the abifebatide abciximab. This we'll discuss maybe in a few minutes. Those to be offered for patients with high risk feature, as we highlighted earlier. I have received some interesting question after the stable ischemic heart disease lecture regarding the duration, whether it has to be 1 year, it has to be less, it has to be more. So as we mentioned, in general recommendation at least 12 months, general recommendation, okay? But related to this one, because what we learn always in the clinical or the therapeutics, that not all the patients are the same, and there is no general recommendation applied as a rule. Sometimes there are individualized decision for each case. So one of the interesting points we can discuss, the early discontinuation. Is there any early discontinuation for the dual antiplatelet therapy? Dual antiplatelet therapy is DAPT. So as we know, the class 1 recommendation, 12 months. Okay, I think this one clear. And this clear that early discontinuation less or earlier than 12 months will have a risk of will have maybe to be supported by risk of morbidity if you continue further. The high risk of bleeding will be there and the benefit will not be that much. And that's why in general the recommendation for shorter duration of that can be considered if patient with stable ischemic heart disease who undergone elective stent placement with PCI, for whom 6 months would be enough. And with high bleeding risk, of course, sometimes the PPI can help. What about the other side of the story? This not shorter duration, the longer duration. So in general, longer duration may be reasonable for the other way around. For those patients have high ischemic events risk and low bleeding risk. And the risk of getting stent thrombosis will be greater on the cessation. There's evidence to do this one. And the dual antiplatelet therapy may be reasonable beyond the 12 months. We exceed this one if in patient high risk and no significant bleeding risk, as I mentioned. The class of recommendation is not that strong, and a longer duration of the P2Y12 inhibitor should be an individualized approach. Okay, so maybe some of you now, individualized approach. Okay, so what do you mean by individualized approach, and how we can maybe individualize this approach, right? Are you asking yourself this one? If you are asking, and if you still maybe bearing with me in this lecture, of course they must be scored to guide us whether it is high bleeding risk, low bleeding risk, high ischemic event, low ischemic events, and guide us whether to maybe there is evidence to continue or not to continue, right? So we have that score. Dual antiplatelet therapy score. This one help to decide, to help in the making decision whether to extend or prolong the DAPT in given case or not. Usually higher score 2 or greater, prolonged dual antiplatelet therapy will most likely to reduce the events compared to infer or confer bleeding risk. And low scores less than 2, the benefit risk ratio for the prolonged therapy is not favorable, means it is not with continue beyond the 12 months if low score. The duration of more or less than 12 months should jointly made by, of course, clinical judgment and balancing again the ischemic and bleeding risk. Okay, at that point, of course, you ask yourself, this 2 score based on what? So it is based on this one. So this is a factor to be considered in finalizing the DAPT score, to see whether high score so favor to continue or low score favor to not to extend. So this all regarding the antiplatelet. Now it is the anticoagulant, the other part of the story in terms of the general management of the non-STEMI and STEMI. you can see in general we have choices: enoxaparin, fondaparinux, unfractionated heparin, and bivalirudin. Usually it has to be offered during the index hospitalization, during hospitalization up to 8 days, okay, until the revascularization takes place. In patient have the cappage as we highlighted in the, if you remember, highlighted in the algorithm, the unfractionated heparin will be preferred. And for invasive strategy, the guidelines high level of evidence for enoxaparin, but of course the bleeding risk is a bit maybe alarming. The guidelines give preference to the fondaparinux in patient who are increased risk of bleeding and treating by the ischemic guided approach. Ischemic guided approach and high risk of bleeding, fondaparinux will be preferred. If fondaparinux used for the PCI, which is not recommended, I think from the very beginning in the PCI, if you remember, we have unfractionated heparin and bivalirudin. This is a recommendation. If to be offered in the PCI, actually another anticoagulant to be there because it's not that effective. The bivalirudin, the one we highlighted, it has been found to be associated by lower mortality or lower ischemia compared to unfractionated heparin plus the GP2 2P3A inhibitor. Bivalirudin compared to the unfractionated heparin, no difference. That's why we recommend either one of them. Okay. Usually, you choose either one of the anticoagulant based on the bleeding risk, based on concomitant therapy, based on renal function. Okay. Of course, in your clinical cases, you have so many examples of the anticoagulant choice based on the renal function. So overall, to maybe close this this page of the anticoagulant, you can see here overall the bivalirudin, all the indication: STEMI, primary PCI, fibrinolytic; non-STEMI, early invasive, ischemic guided. You can see bivalirudin is not recommended in fibrinolytic reperfusion in the STEMI, or the ischemic guided in the non-STEMI. For the other two, okay. Enoxaparin, okay, to be offered, but the risk of bleeding could be troublesome in some patients. Fondaparinux, no recommendation in the PCI. Could be an option in the others. Unfractionated heparin, option in all. The one we have highlighted, the GP2P3A inhibitor, and to be offered in high-risk individual and all the data regarding them. The high-risk feature, especially in patient with PCI, in patient with high-risk maybe feature that we have highlighted earlier. We have 3 agents: abciximab, eptifibatide, and tirofiban. For them, usually this one is not a routine recommendation, and routine recommendation means not to be considered for all. I have received one question regarding this point. Not to be considered for all. You can say the conventional management also can do the same, or can refer to the same meaning. The benefit from adding one of these agents to the aspirin is very relevant if the patient has one of the high-risk features that we highlighted earlier: highly elevated biomarkers, diabetes, or revascularization procedure they will undergo. And for those patients not receiving adequate pre-treatment with clopidogrel and ticagrelor, usually aspirin and those treatment will be offered before those agents. For this patient not adequately treated, they will have some benefit from this agent. The abciximab, the double-dose eptifibatide, and the high-dose tirofiban are all of the same recommendation. Either one will do the job. Preferred option: relatively eptifibatide and tirofiban. Most studies, if you are administered GP any one of abciximab, eptifibatide, and tirofiban as one of the antiplatelet, in this case better the anticoagulant to be unfractionated heparin. Okay. The upstream and downstream. Upstream means we offer this one before the PCI. The downstream is over at the time of the PCI, usually the upstream administration is non-inferior to delay the timing of reduce the ischemic events. Non-inferior means as effective as, okay? Significantly higher bleeding rate in those patients receiving before the PCI. So in terms of efficacy is okay. In terms of bleeding risk is high. So again, weighting the risk. So in patient who is not undergoing the PCI, the bleeding risk outweigh any benefit, and the combination of those agents with any of the fibrinolytic therapy should be avoided. The highest bleeding risk and the consequences will be very severe. So reperfusion strategy, as we mentioned, we have the primary PCI that can be offered is 12 up to 12 hours, and then later will be assessed if done okay, if may be fed, and another one will be rescue PCI, and later will be the angiography, the elective one. So now we understand the supportive measures or supportive therapy. We understand, or we hopefully we highlighted the antiplatelet and the anticoagulant, which is the main, okay? The remaining one for us in terms of the pharmacotherapy, the fibrinolytic therapy, in terms of the agents to be offered in acute setting. Fibrinolytic therapy, brothers and sisters, to be offered in whom? STEMI or non-STEMI, based on the 1 hour plus we are discussing. Fibrinolytic therapy, to whom should be offered? Assalamualaikum.
Waalaikumsalam.
Are you still here?
Yes. Doctor, I think STEMI.
Yes, excellent, sister. Thank you so much. Fibrinolytic therapy, of course, we offer we highlighted in the STEMI, brothers and sisters. We highlighted in the STEMI either the revascularization, either the PCI or fibrinolytic therapy based on the PCI facility, whether the PCI available or not. PCI available within 90 minutes, okay. PCI not available, go for fibrinolysis, okay. The agents to be offered: altiplase, retiplase, tenecteplase, any one of them. And you can see here, the altiplase actually is getting infusion. The other two is a bolus. This double bolus separated by 30 minutes. This a single bolus should be weight adjusted. Fibrinolytic therapy, as we mentioned, this one I made it writing just to confirm the information I already presented earlier in the algorithm. So this one indicated for patient with STEMI, thank you, sister, again, whom the PCI cannot be done within 100 or within 2 hours, 120 minutes of first medical contact. The ideal door to needle is less than 30 minutes. Door to needle, just enter and the needle for the injection. The guidelines don't prefer one agent over the other. It depends on every place, what the available altiplase, tenecteplase, whatsoever. The patient undergoing reperfusion with fibrinolytics should receive anticoagulant. Anticoagulant should be there. And of course, maybe as you may be fully aware or no, the fibrinolytic therapy has some relative and absolute contraindication. To evaluate even the patient is a candidate or not, you should go back and see whether, okay, this blood pressure is very high blood pressure, so we have to wait, we have to manage, because this one relative contraindication. This is trauma, this active peptic ulcer disease for bleeding, it is pregnant, is the patient currently taking oral anticoagulant before the fibrinolytic therapy. All these agents to be evaluated. Relative means can be subjected to the clinical judgment. It is not absolute contraindication. The other side, the absolute contraindication, means any patient with this characteristic is not even an agent to consider fibrinolytic therapy of course, ischemic stroke within the very recent onset within 3 months, aortic dissection, and then this very active internal bleeding, very serious. All this is not indication. Some of the cases you will find, you have the point we have highlighted here, the blood pressure, for example, is the patient on presentation have a high blood pressure, but he has no other absolute contraindication for fibrinolytic therapy. In those patients, what should be done? So in this patient, uncontrolled presentation, you have to get immediate IV medication that bring the blood pressure control, and then later you can introduce the fibrinolytic therapy. Once the systolic come below the 180 and the systolic 110, the fibrinolytic therapy can be administered. Okay. Compared to the alteplase, the tenecteplase show no difference in mortality, but relatively fewer bleeding complication. The elderly patient still can be offered, because it's still some mortality benefit can be attained. And in this elderly patient, actually there's some strategy to decrease the potential risk of course the bleeding risk. So agent of choice, for example, it is recommended, as we highlighted, that tenecteplase is less bleeding. So perhaps in those patients with relatively higher risk, the less bleeding associated medication tenecteplase would be preferred. Okay, and this has been shown in one study among elderly patients who were female at that time. They are considerably have low rates of major bleeding or intracerebral hemorrhage. The use of reduced fibrinolytic therapy also one of the strategy, not giving the full dose. Okay. Monitoring for the successful, of course, you give fibrinolytic therapy, and the main aim to what? To restore the patency of the article. So for the artery. So open the infarct-related artery is the main outcome, and maybe within time, if a resolution of more than 50% of the ST segment elevation happen between 60 to 90 minutes while you're initiating the fibrinolysis, will be good indicator that the reperfusion is going with the good response and the good outcome. So to see or to say this adequate reperfusion, no need for rescue PCI, no need for any other measures. Relief of symptoms, of course, maintenance the hemodynamics, and reduction more than 70% in the initial ST segment elevation. Okay? Okay, brothers and sisters?
Okay, doctor.
Okay, so now regarding the management to be done or to be offered for both STEMI and non-STEMI in all the acute settings, whether this whether the supportive measure management, the antiplatelet, the anticoagulant, the fibrinolytic therapy, we all covered this one, and we're almost done. And one good point just to be considered for all patients with ACS, the long-term therapy. Long-term therapy, we will not take long for this one, because this one is of a bit similar to what we have discussed last week in the ischemic heart disease. The recommendation is almost same, because the long-term management. So smoking cessation with management, and of course the diabetic control in relevant patients. And the continuing of the beta blocker, statin, the aspirin, the dual antiplatelet therapy, as we mentioned, for at least 12 months to be extended or not. The aldosterone antagonist in certain subset of patients, and those patients with left ventricular ejection fraction less than 40, with hypertension, diabetes, or CKD, of course, they will benefit from ACE or ARB treatment. Okay, I think this one in general, not really different from what we have discussed last week, but this one may be one of the treatment algorithm, because this is charge plan. So now we have already, alhamdulillah, we consider ourselves already done. Now we just maybe sum up or wrap up whatever we have mentioned in terms of recommendation of the guidelines. So reperfusion therapy, again, I remember for those of you maybe sleep for some time or maybe get lost in between. If you can bear attention now, we can just summarize whatever we mentioned in the 2 hours in 5 minutes. So reperfusion therapy, this for STEMI or non-STEMI? Brothers and sisters, this for whom? For which SAS? Okay, I didn't hear. Is there any answer? You can write in the chat even.
In STEMI, Doctor?
STEMI, yes, exactly, sister. So the reperfusion therapy, which to be offered in the STEMI patient, the primary PCI with the recommended time interval is 90 minutes. There are contraindications to fibrinolysis and high-risk patient. Fibrolytic therapy, this one, though to prolong time, 90 minutes at first medical contact in a PCI center, or more than 120 minutes if transformed from non-PCI center. No contraindication to fibrinolysis in this one should be there, and I show you the relative and absolute contraindication. Okay, this is just a summary, nothing new here, nothing new. Again, concomitant therapy, brothers and sisters, this is STEMI or non-STEMI? This concomitant therapy, the antiplatelet or anticoagulant? Antiplatelet here, antiplatelet, okay, or anticoagulant. This is STEMI or non-STEMI?
Non-STEMI. Both?
Both, yes, both. Both, of course, we mentioned this antiplatelet, antithrombotic, of course, for both, right? In the further selection of agents, there are some agents to be offered in the PCI only, PCI under the STEMI. Some other agent can be offered for both. But the recommendation for antiplatelet, antithrombotic, this for both, right? You can see here either maybe medical or PCI, clopidogrel, ticagrelor plus aspirin, prasugrel in patient only prior to the primary PCI. Okay. What about the anticoagulant? You can see here the recommendation. If no PCI, you can offer either one. If PCI and anticoagulation also, you can consider long-term maybe oral anticoagulant and dual antiplatelet therapy. Okay. For concomitant therapy, this one, brother and sister, for both or for which patient category? This a long-term management. This a general for all. You can see the higher level and grade of evidence. Beta blocker to be initiated, ACE inhibitor to be initiated, and high dose statin to be initiated, and this is very important. You can see here just maybe in both STEMI, you can see a summary of the smoking cessation, the exercise, the aspirin, what actually the recommended dosing, plus clopidogrel, preferably 1 year. All these points we have already highlighted. Ticagrelor and the difference between the dosing and up to 1 year. Again, prasugrel and up to 1 year post-primary PCI compared to others. Okay. This may be a detailed maybe of the recommendation pertaining to the beta blocker. So beta blocker, one of a good question, brothers and sisters, for the duration. When we say long-term management beta blocker, long-term management statin, long-term management ACE inhibitor, this long-term refer to how long? It is 6 months, it is 1 year, it is 5 years, it is 10 years. What do you think? So long-term therapy usually refer to at least 1 year. Some of the reference maybe pertaining to the beta blocker mention 1 year to 3 years, continuously. Okay, but the high level and grade of evidence for maybe approximately maybe long term, more than 1 year or 1 year at least. Okay, statin indefinitely, because this one will be secondary prevention. High dose statin should be there as long as the patient tolerate, and in this case the LDL should be at least 1.8 or below, or a 50% reduction from the baseline. The baseline we started in the statin arm, and I think maybe we can explain a little bit more in the hyperlipidemia, inshallah. So this all regarding the recommendation, what we call the performance measures. Performance measures means if we want to say that the STEMI management in our clinical settings is up to the level, and maybe the target has been achieved, you have to observe these measures. These measures like maybe the timing, how fast we acting the first medical contact to device in terms of the PCI, or to the needle in terms of the fibrinolysis, and how the percentage of the patient has been already getting the dual antiplatelet and therapy and the statin on discharge, and those with left ventricular ejection fraction less than 40%, have they been offered this treatment? At least this actually the percentage at least to be achieved. If we are 90%, all the patients on discharge have this one is good. Okay, so the KPI for management of STEMI has been achieved. The outcome measures, even if we apply all these, and it has to impact on the mortality to make the in-hospital mortality less than 10, the 30-day mortality less than 14%, and the 1-year mortality less than 18%. And this one again is indicative of the successful treatment in a given case. If you want to have a look overall, this one this a summary, I think, from the pharmacotherapy book regarding the monitoring. What I have, maybe I can highlight for you here. You can see the bleeding risk. The bleeding risk is one of the common maybe problem with the agents that can be offered in the clinical care of STEMI and non-STEMI, which is the antiplatelet and antithrombotic, which is maybe requires more maybe vigilant monitoring, and sometimes can guide the choice even of which agent to be offered and to be replaced by another agent of higher bleeding risk. Okay. So, brother and sister, alhamdulillah, we have done. So what I can say as a summary, usually in the ACS management, with the use of the invasive strategy, the outcome will be much better. The survival much better. The major risk associated with thrombolysis is a bleeding, which is maybe very serious. It has to be assessed and will guide the choice of the treatment. The aspirin, all ACS patients unless contraindication. The other agent, the B2Y12, the clopidogrel, ticagrelor, and all other agents are recommended with aspirin in patients with ACS, all patients with or without stenting. The beta blocker and statin, almost for all. The ACE inhibitor, ARP, and the steroid antagonist will be for subset of patients, as we highlighted. The nitrates are useful in the supportive measures, and the secondary prevention with focusing on lifestyle modification and lipid-lowering therapy and the adherence to the long-term therapy is of paramount importance in given cases. I think this one you can read in your own. Usually, I place the patient care process at the end, that you feel like it makes sense as a summary. You can see here all whatever we have mentioned regarding the ECG, the cardiac parameters, all the agents, the therapy evaluation, the pharmacotherapy for the ACS, and all the relative or the significant agents that usually will be in the ACS pharmacotherapy plan. The appropriate treatment strategy now that decide which treatment modality I think should be clear. For non-STEMI, ischemic guided invasive. For STEMI, the PCI or fibrinolysis for revascularization. The contraindication for therapeutic therapy is good to consider. The stratification of the risk assessment, discontinuation of the medication with bleeding risk is also very important. The anti-ischemic treatment in general is a supportive measure. Again, the nitroglycerin and aspirin that we highlighted to be offered in all patients is very important. Other potential contraindication for that maybe exacerbate the bleeding risk is also very significant. Choose appropriate antiplatelet anticoagulant, and this one we highlighted. Certain agents to be offered in certain subset of modality and not to be used in others. Fondaparinux in PCI, for example. The renal function and the coagulation profile can guide which agent to be used. Signs and symptoms of bleeding as one of the monitoring parameters is very important. The beta blocker and the timing. Review discharge prescription. What agents you expect a discharge plan for any patient with STEMI and non-STEMI will contain what? The dual antiplatelet therapy, the statin, the beta blocker, all these agents you should look for. If you want to decrease the bleeding risk, assess whether the patient has to be receiving the PPI therapy or not. Ischemic medication in discharge to be there is very important. And the follow-up evaluation, how frequent and how to be conducted. All this patient care process, nothing new. I just maybe try to make a summary of the points as maybe a healthcare professional should look at this point at this stage of the treatment. I think that's all from my side. Hope inshallah everything is clear at your side. If you want to go for some cases, you can see here some cases. Brothers and sisters, are you still around?
Yes, certain.
Okay. Maybe I realize maybe getting the ACS in the first 2 hours in the morning, 2 consecutive hours, is not an easy task. It is not an easy also for you as a receiver, but hopefully this one enable to collect all the information together. And last time we done it in two consecutive weeks, so it is what was a bit challenging to introduce in one lecture and continue the following week. I think this time, maybe although it is a bit challenging, but it is good that we have the topic in one session. Hopefully, you now maybe after referring to the slides, inshallah, and have a look, you can go for the cases. I will not make it that long, so I will keep the cases for you. And if any further explanation, I can do inshallah in the next slide, or we can even discuss on the chat on the team if you want any response regarding maybe the answer of these cases or whatever. We have 4 questions here. The first one related to scenario and maybe giving you in this patient with this non-STEMI, which one of the treatment options should be the most appropriate. Okay, so develop maybe our understanding, what are the similarities, what are the differences between each and every ACS presentation, and by this way, inshallah, you can find it easy, inshallah. The depth timing. Okay, the point may be extended or shorter duration, or just maybe within the recommended approach. We have discussed this one, the depth score. this regarding the strategy again, which strategy to be offered based on the case scenario. This patient with STEMI, which one to be offered? Okay. So in the STEMI, for example, you have two main ways: reperfusion, the PCI, fibrinolysis. Okay, which one? This easy. If you go for this one, and in which basis you decide for this one and this one, I think maybe should be no problem. And the last case is again around the regimen to be offered, and giving you some time here for the presentation to cath lab, and based on this one, this STEMI patient and this agent already has been offered. So what is the next? What should be the next step? Okay. Thank you so much for your time. Okay, there's some answer. Inpatient STEMI, non-STEMI. Oh, this and all the answers. Okay, thank you all for your response, and thank you all for maybe waking up so early to listen to ACS, which is a bit challenging. If any further clarification and even checking for the answers or whatsoever, you can use the team, or you can maybe chat here or WhatsApp or email, no problem. I give you opportunity first to go for the topic, to just maybe sum up in your mind the content. And for one sister, I think from the first part, myocardial injury can cause by non-ischemic. Sometimes non-ischemic causes can predispose to the myocardial injury. One of them, the spasm, the persistent spasm, not ischemia. Persistent spasm for sometimes can predispose to myocardial injury. One of the causes. Okay. Thank you so much. Do you have any further questions, any points before we end our session?
So far, no, Doctor.
Okay, so far you are happy that you finished even. Okay. Okay, thank you so much. Thank you so much. We can end our session by Tasbih Kafara and so on. I will check the email regarding the attendance. If regarding the attendance, I think Dr. Eid mentioned he created the attendance right, Ali. That's why I didn't